Hi everyone, I'm Dr. Michael Richmond, a double board certified cardiothoracic surgeon. Yesterday in my video, I talked about the initial approach to a thyroid nodule, and I concluded with the indications when to do a fine needle aspiration. Today is part 2 as promised, so let's talk about the results of the FNA. Okay, so first, the pathology is consistent with a benign cytology, meaning it's not cancer. Patients with benign nodules, which are either classified as macrofollicular or adenomatoid or hyperplastic nodules, colloid adenomas, nodular goiter, and Hashimoto's thyroiditis, are usually followed without treatment. In the absence of a history of childhood neck irradiation, patients with benign nodules should not be treated with T4, which is levothyroxine. Just so you know what levothyroxine does, it can suppress a thyroid nodule by lowering serum TSH levels, thereby reducing TSH-driven stimulation of thyroid tissue, including the nodules. TSH is a trophic hormone that promotes growth and activity of thyroid cells. So suppressing TSH with levothyroxine can decrease nodule size or prevent further growth in some cases. Periodic ultrasound monitoring of benign nodules, initially at 12 to 24 months, then at increasing intervals over time, in other words, every 3 to 5 years, with the shorter interval for large nodules or nodules with worrisome ultrasound features, which I discussed yesterday, and the longer interval for smaller nodules with classic benign ultrasonographic features. We repeat the FNA within 12 months if the nodule has highly suspicious ultrasound features, despite having a benign or non-cancerous biopsy. Small changes in nodule size on serial ultrasonography do not require a repeat aspiration. Do not. If a nodule is reaspirated and the second cytology is benign, ultrasound assessment of this particular nodule for possible risk of malignancy or turning into cancer is no longer necessary. Okay, the second thing, the pathology report says the FNA is consistent with non-diagnostic cytology. For patients with non-diagnostic or ultrasound-guided biopsies, we perform repeat FNA using ultrasound guidance. For patients with solid nodules and non-diagnostic cytology, after repeated biopsies, we typically perform an ultrasound-guided core needle biopsy, which is thicker. Careful follow-up, repeat FNA, and surgical resection are alternative options. For cytologically non-diagnostic nodules that are predominantly cystic, we suggest careful follow-up with ultrasound monitoring rather than surgical resection. Third, it is read as indeterminate. In other words, nodules with indeterminate cytology, which are known as atypia of undetermined significance, or AUS, or follicular lesions of unknown significance. The risk of malignancy with these cytologic classifications range from 13 to 30% and 23 to 34% respectively. So the approach varies with institutional practices and availability of molecular testing, which is NGS. Unless a sample for molecular testing was saved at the time of the initial biopsy, a repeat FNA with a sample for molecular testing, if available, after a 6 to 12 week interval or earlier, is indicated in most patients with indeterminate cytology. It also may be possible to do a mutational analysis on a sample obtained by scraping the cytology side from the initial biopsy on the slide, which eliminates the need for a repeat FNA. If the TSH is subnormal, indicating overt or subclinical hyperthyroidism, and the nodule shows AUS with architectural atypia or follicular neoplasm, the possibility that the nodule is hyperfunctioning, a hot nodule, is increased, and thyroid scintigraphy should be obtained, and we discussed that yesterday, if not previously performed prior to repeating the FNA. Some experts also perform thyroid scintigraphy if the TSH is in the lower end of the normal range, in other words, less than 1 milliunit per liter, as thyroid hormone production from some self-functioning nodules may suppress TSH only within the lower portion of the normal range. Since hot nodules rarely are cancer, a nodule that is, quote, hot on scintigraphy does not require repeat or even initial FNA. Repeat FNA should be performed in patients with non-functioning, in other words, cold nodules. If molecular testing is available, either at initial or subsequent FNA, further management then depends on the results of the molecular testing. I've discussed NGS in a previous video, and I suggest watching it. If molecular testing is unavailable and repeat aspirates continue to show follicular neoplasm of unknown significance, or AUS, we suggest diagnostic surgery, typically a thyroid lobectomy. Finally, the results on the FNA are read as suspicious for malignancy, also known as Bethesda 5 nodule, or a malignancy, also known as a Bethesda 6 nodule. Patients with nodules that are suspicious for malignancy or definitely malignant should be referred for surgery. So in my next video tomorrow, I will start discussing thyroid cancer, since there are several types. And with that, I hope you learned something today. Thank you so much for listening. For more information or guidance, you can go to my company website at www.paladinmds.com, and hope you have a great day. Thank you.